right, as people come in, good afternoon and welcome to the second session now of the ROVER summer session for medical students. We have a great lineup this afternoon. We'll be talking about both CNS and pediatric malignancies with our esteemed panel. We have Dr. Susie Hineker from Stanford, who specializes in pediatrics. We have Dr. Tim Harris from Virginia Commonwealth University, who does both CNS and peds. And then we have Dr. Michelle Kim from the University of Michigan, who specializes in CNS malignancies. So we're going to do some cases this afternoon, which will be moderated by Jacob Miller from Stanford. And we're going to ask that you use the chat box throughout the cases. If you have questions or comments, some will be answered live by the panelists, and others we will try and get to during the session in the chat. So to get us started, would you each like to introduce yourselves and maybe tell us a little bit about how you found radiation oncology? Go ahead, Susie.
Yeah, sounds good. I'm Susie Hineker. Nice to meet everyone. I do mostly pediatrics at Stanford. I got into radiation oncology, really started during college when I worked as a nurse's aide in a bone marrow transplant unit and knew that I loved oncology and wanted to find some way of doing that. And then throughout medical school, I found that I really liked the amount of time that radiation oncologists got to spend with patients and the research aspects of it. And I also like, being there for an intense part of a patient's treatment, but not necessarily being their primary person. So it's a great field.
My name is Tim Harris, and I got interested in radiation oncology really during my PhD years. I worked in a tumor immunology laboratory, primarily with medical oncologists, and so those are the chemotherapy specialists. And so that was initially where my interest was, but my mentors there said that I should definitely consider other aspects of oncology. So very early on, I was able to just do shadowing with surgical oncologists, urologists, as well as radiation oncologists. And as I went through my PhD, began really exploring the interaction between radiation and the immune system with something called the abscopal effect, which is when radiation can augment an anti-cancer immune response. And so based on my basic research and my preclinical research, that got me very interested in radiation oncology clinically. And so that's what I pursued thereafter.
Hi, everyone. My name is Michelle Kim, and I actually had really early exposure, I guess, to the field because even in elementary school, my dad's actually a radiation oncologist, so I'd actually heard of the field very, very early. I had no idea what it was about, though, until I met really wonderful mentors further along who kind of shepherded me in research and then exposure to the clinical radiation oncology side of things, more starting the beginning of medical school. So early on, probably some of you are. And then since then, I've just known that it's, I think, the best specialty there is.
Hey, everybody. Good afternoon. I'm Jacob. I'm in my last year of residency at Stanford, and I'd want to echo what Dr. Kim said. I actually went into the field mainly because of mentors. I went to sort of a small medical school, and so I knew some of the students who had graduated and stayed on in rad onc residency at the same institution, and they were just great mentors for me, not just for research projects, but also for just deciding what specialty to go into and shadowing in clinic. And ultimately, I just love the outpatient setting and seeing patients and follow-up. So it's been great. So I think with that, we can start our first case. I'll be moderating the session. It's a CNS case. So this is a patient that I actually saw in my CNS rotation. It's a 62-year-old man who comes to the emergency room complaining of weakness, confusion, and headaches that were kind of over the course of several months. Exams showed that he was walking with a wide-based gait. He didn't have any specific neurologic deficits that the ER doctors could point to, but he's just not feeling well. Labs didn't show anything, and they got a non-contrast head CT in the emergency room, which looks like this. So I'll just scroll through this. So it showed that mass in the brain. And the radiologist report noted about a 6-centimeter mass in the right frontal lobe of the brain. There was some midline shift, meaning the tumor was pushing the brain to the across midline. And there was some edema in the brain that was noted. They did get a CT of the rest of the body that didn't show anything, and then an MRI was performed. And so as I scroll through these, maybe Dr. Kim, while I'm scrolling through these different MRI sequences, can you kind of explain what you're seeing, what your approach is to reviewing MRIs, and maybe what your initial impression is?
So it's obviously, makes sense why he would come in with some alterations in his mental status. This is obviously a very abnormal looking scan. Normally these scans, just like you see in your textbooks, have sort of they're very symmetric. The brain is extremely symmetric. This is obviously asymmetric. And I think even, one would guess that this could be a pretty aggressive process, just given the way that it's sort of pushing and making the brain look so abnormal. It's also kind of, the medical term we use is heterogeneous. So there's like dark spots to it, but there's also bright spots, which if you're suspecting something like a brain tumor, although that's probably not the only thing you might suspect here, but if you are, is probably not a good sign.
Thank you. And so that's exactly what the radiologist reported. So the report showed a 7-centimeter mass that was enhancing. So it was taking up the contrast that was given. In the right frontal lobe, it was cystic. And as Dr. Kim said, there's areas where maybe there's a solid mass, and then other areas where there's necrosis or fluid, and then edema, which was also shown on the CT scan. So this will bring us to our first audience poll. So based upon this patient's age, maybe how long the symptoms have been going on, and the imaging that's been shown to you thus far, what is your leading differential diagnosis? And then we'll give some time for our participants and audience to answer, and then we'll turn it over to the panel. Okay, so everybody can see that. So most people answered glioma. Maybe Dr. Harris, what do you think when you see these images and you see a 60-year-old coming in the emergency room with these imaging findings?
I think, given the imaging findings and the lack of anything found on the CT of the chest, abdomen, and pelvis, that would lead me to think that this was a primary brain tumor, like a glioma or a glioblastoma. If we saw evidence of advanced disease, let's say like lung cancer or colorectal cancer on the CT scans, then potentially a brain metastasis. We definitely can have brain metastasis that look that nasty as well. But yeah, given the lack of those findings on the CT of the chest, abdomen, and pelvis, a glioblastoma would be the highest on my differential.
Thank you. And most of the audience said that they think this is a glioma. Dr. Kim, you mentioned some of the imaging features. What helps you when you're looking at an MRI distinguish between different maybe types of gliomas?
Yeah, so you know, as a radiation oncologist, you get accustomed to looking at many scans. And if you treat patients with central nervous system tumors, in particular MRI scans, which can be a little hard to interpret. But in looking at these for some time, you know, the term that we use is contrast enhancing, and that just means the bright areas that you can see on the scan, which are partially a consequence of the contrast, the gadolinium, sort of extravasating abnormally across what is normally intact blood-brain, or in this case, there's a blood tumor barrier. So many types of aggressive brain tumors, a number of which were listed on that poll, will show this kind of contrast enhancement. But more subtle than this, you know, there can also be what we call non-enhancing areas, which are not bright like this and may show up better on a scan such as the one to the right, which is what is known as a T2 weighted MRI scan. And so if I saw something that was entirely not bright but looked abnormal on a T2 weighted MRI scan, that would lead me more to thinking along the lines of perhaps lower grade, or maybe like a less aggressive disease process, and maybe something that's perhaps not even a cancer. So there's different ways that you can evaluate the way the appearance of these entities on a scan to lead you one way or another.
Excellent. Thanks so much. And so this specific patient, you know, they were admitted from the emergency room and neurosurgery was consulted, and neurosurgery did a biopsy, for example, first. And this is the histologic diagnosis that was listed. So glioblastoma, which I think Dr. Harris and Dr. Kim mentioned, IDH wild type, WHO grade 4, MGMT, non-methylated, and they list some of the histologic features of the glioblastoma here. So again, for our panel, what when you read these, why are all these extra things listed? Why isn't just glioblastoma sufficient? And when you're thinking about managing a patient as a radiation oncologist, why are these important to you?
So, you know, more and more as we've gotten a better understanding molecularly of tumors, CNS tumors as well, you know, we've begun to really define them based on their molecular characteristics rather than histologic, meaning what we see under the microscope slide just with an H and E. And so probably the recent changes with just the WHO classification for 2021, you know, now has glioblastoma being really defined by having a wild type IDH. And so that's, you know, what we would look for now, just being definitive of what a glioblastoma is, being IDH wild type. We also look at MGMT, whether or not it's hypermethylated or not. And I know that's maybe one of the next questions, so I don't want to necessarily get ahead of that. But I think the purpose of these, one is prognosis for sure, both with IDH as well as MGMT. But moving forward, IDH also is going to be definitive for what a glioblastoma is.
And some of you may recall, I mean, when we say IDH, we are referring to that enzyme that you would have learned about probably first year in biochemistry, involved in the metabolic pathways in Krebs cycle. It's isocitrate dehydrogenase. So a number of those kind of sort of more basic science facts that you learn in medical school actually have arisen again in our understanding of like these tumors, and we integrate that, just like Dr. Harris said, in our thought process and understanding of these tumors.
And so if IDH is mutated rather than wild type, then that would mean that it's not a glioblastoma. It would either be astrocytoma or an oligodendroglioma, depending on other molecular characteristics like 1p19q codeletion.
So this patient, after they had their actual diagnosis from the biopsy, the neurosurgeon did a craniotomy, so removing a flap of bone from the skull and resected this right frontal brain tumor. This patient did well postoperatively in the hospital and was discharged. And so they did get an MRI of the brain on the postoperative day 1, and it shows these here, the axial scan on the left without contrast and with contrast on the right. Again, for our panel, when you're reviewing these postoperative scans, what are you looking for a glioblastoma, and why does that matter? Why do they even bother getting an MRI after the surgery, after it's been removed?
So in terms of just general principles of cancer in general, not just specific to brain tumors, but before you as a radiation oncologist treats a patient, you want to understand fundamentally what it is, what its name is, but also how much disease there is and where it's located. And that's really the purpose of these scans, and that even though this surgeon has performed a very good removal of the tumor, you can see there's essentially complete removal of that portion that we called contrast enhancing. Still, what we know based on numerous studies and even experiments when they went in and actually serially biopsied regions of the brain remote from the visible area of disease, or they did sectioning of brain specimens on autopsy, that these tumor types tend to have these fingers that extend for many centimeters beyond the visible area that was removed. So based on that and just a number of clinical trials, we can state that this patient had a maximal or a gross total resection, but which is important to know. That's an important favorable prognostic factor in terms of their survival. But we know that adding treatment in the form of radiation therapy and chemotherapy beyond that will actually extend their survival as well. So a lot of what we determine and do is based on clinical trials and randomized evidence to help us make a decision for the individual patient who's in front of us.
Thanks so much, Dr. Kim. And then, so for this patient, they were discharged. The MRI did show essentially a gross total resection. There was a small area lower down in the brain. I think the radiologists were concerned that it might be some residual disease. But as the radiation oncologist, we ended up meeting the patient in consult about 2 weeks after they were discharged. I'll show this Craniospinal performance status, and we'll talk about it a little bit later. That patient 70, their performance status is 62. So again, for the audience, if you're seeing this patient in radiation oncology clinic for the first time, they have a glioblastoma. Let's say it's been removed or maximally removed with as much as they can. What's your recommendation for how this patient should be treated? Okay. Okay, so here's the results. Looks like a whole variety of responses between whole brain radiation, chemotherapy with radiation to the surgical cavity, combinations of chemotherapy and radiation, and then waiting until the patient kind of we're able to see more disease on the scans and then treating the patient at that time. So we'll talk about each of these considerations in a little bit, particularly in light of the patient's age and what their functional status is. So we ended up recommending chemoradiation or chemoradiotherapy, a combination of radiation with chemotherapy to the surgical cavity to a dose of 60 gray and 30 fractions. We'll talk a little bit about the treatment planning shortly. And then this concurrent temozolomide. This is the chemotherapy. It's taken orally that the patient takes each day. And now this is sort of, we'll talk a little bit about the other part of our responsibilities, which is all the treatment planning and actually getting the patient from initially being seen in clinic to getting the treatment started. So the patient came into our department afterwards. He wanted to proceed with radiation. He had a simulation session or a planning session, and he was simulated laying down with a mask with IV contrast, and we got a CT scan at that time. So for our next poll, and then we'll also be talking with the panel, what are your target volumes? So how do you actually contour this and define what you're going to treat? And then for our panel, when you have a glioblastoma that you're treating, how do you think about defining your targets, what you're going to treat, and what you think is safe to not treat? I'll just give about 30 seconds for the audience. Okay, so that was the audience results, and then I'll just pull this up. So before we talk about how the maybe treatment volumes or target volumes are for glioblastoma, Dr. Hineker, can you discuss what these different terms are, GTV, CTV, PTV, and how radiation oncologists think about these?
Definitely. So the GTV represents where the actual tumor is or was, so would really represent the resection cavity in this situation. And that's probably at highest risk for any residual disease, even though we can't see anything on imaging. The CTV is an anatomic concept, so it represents areas really of potential microscopic spread. So where could the cells be that we can't appreciate on imaging, but you know, by anatomy, where can they physically go? And then the PTV is really a geometric concept, and that represents a small margin added for setup variation from day to day. So you'll see on this screen that the GTV is really your resection cavity. So that's where the tumor was and where it collapsed to after it came out. The yellow is the CTV. And so typically here we add about 2 centimeters to the resection cavity. And you can shave it off of any areas where it is not logical for the cells to be able to travel. So right there, like across the falx, they can't go there, and so you can make it smaller there. Now lower down, you see that that area is extended over to the other side because the cells can cross in that area of the brain. And then the green area is the PTV. That's just about a 3 millimeter margin we use, and that can account for any very small variations in day-to-day setup. Yeah.
Thanks, Dr. Hineker. So for our panel, how do you, when you're treating a patient with glioblastoma after surgery, how do you maybe define your target volumes and introduce us to when you're looking at a radiation treatment plan, which is what we see here, what are you looking for to determine whether or not you want to proceed with treating the patient with that plan, or how would you work with your team to make a better plan?
For glioblastoma, I still use 2 volumes, which is standard in the United States as opposed to Europe, where they lots of times just use 1 high dose volume. So my high dose volume would still be any areas of enhancement or the resection cavity. And I usually add a margin from that GTV to a CTV of anywhere between 1.5 to 2 centimeters. And then adding a 3 millimeter PTV to that. Again, with the CTV, respecting, anatomic barriers. So we don't expect for glioblastoma to cross the tentorium, so I would shave anything off with that type of expansion. And really with that, as mentioned before, really just following the pathways within the brain where we would expect it to cross, which we see here sort of crossing the genu of the corpus callosum from the right side to the left. And I also take the T2 or flare hyperintense area and sort of contour that as another GTV, which will go to a lower dose. I also expand that by about 1.5 centimeters for CTV and add a 3 millimeter PTV onto that. Traditionally, both of those combined volumes would go to 46 gray and 23 fractions, and then we would boost the area that we want to go to 60, boost that area by itself up to 60 gray. The way that I generally do it is with the simultaneous integrated boost. And so for the lower dose, which is the expanded T2 or the expanded flare volume, I'm treating that 1.67 gray per day in those 30 fractions, and the high dose area that's expanded from the cavity or from the contrast, I'm taking that 2 gray per day to 60 gray. What I generally am looking at is total volume of brain being treated. If it's a very, very large volume, then I'll definitely take off that low dose and just use more the European approach, just treating 60 gray just to the expanded cavity or enhancing area. What we look at to make sure it's a safe plan is dose to the normal structures or the organs at risk. When we're treating CNS tumors, that would generally be the brain stem as well as the optic pathway, which would be truly dose limiting structures for me. For glioblastomas, I generally keep the brain stem to 60 gray. And the optic pathway, I'll still keep that to 54 gray, but other people for glioblastomas would allow the optic pathway to go higher.
Thank you, Dr. Harris. Yes. Oh, Dr. Kim, go ahead.
Yeah, just to complement what Dr. Harris said, and just to answer the question that Anna posed about the role for proton therapy. Proton therapy, at least for patients with this aggressive tumor type, has not been demonstrated to be advantageous for patients, either in terms of keeping the tumor away for longer or helping to mitigate some of the cognitive sequelae of therapy. That doesn't mean, however, that there aren't potential, possibilities for its use, and that is being investigated in an ongoing national trial, with the thought that maybe if you reduce exposure to some of the circulating pool of immune cells that are actually exposed, if you think about it, to your radiation field, that maybe that could be more beneficial for patients in terms of perhaps even their long-term survival. So this is an area, I think there's two major questions kind of related to what Dr. Miller was asking about in terms of sort of improving the quality of our plans. One is to reduce the side effects of the treatment. So that's an ongoing area of research. Another question, perhaps even equally or if not more pressing, is how to improve the outcomes, because unfortunately, the average survival of patients when they're diagnosed with this particular tumor is about 1.5 years, and that hasn't changed for many, many decades. And so for many times, these patients, we will try to enroll them on clinical trials to help with that very issue. Is there a way that we can safely and appropriately and in a way that maintains their quality of life possibly improve their survival? In fact, I just saw a patient about a couple hours ago where we enrolled them on a clinical trial that's related to this question of, can we maybe better identify the more aggressive tumor regions, maybe with better imaging techniques to make what we're aiming at not just an anatomic concept, but a biologic concept. So where are the aggressive areas that are going to repopulate the tumor and come back? Can we specifically intensify therapy safely against those areas using these specialized scans. This is something that's also being looked at not just in brain cancers, but in other diseases of the body in the field of radiation oncology.
Thank you, Dr. Kim. That's really exciting. And it kind of speaks to one of the other roles we have as radiation oncologists in clinics is not to just, deliver the standard of care that maybe we learned in residency, but also design trials that we're interested in and enroll patients on trials so that we can continue to improve treatments. So this specific patient did complete chemotherapy with radiation with some, these are the expected side effects of this course of treatment: tiredness, hair loss, nausea. An MRI of the brain was repeated after radiation. That showed some post-treatment changes without any progressive disease. So the tumor hadn't grown back during the course of radiation. And then the patient starts chemotherapy after finishing the radiation, which is sort of the current standard of care. So as we close up the first case, I'll just sort of talk about some of the other open to the panel to talk about some of the other variations of how we might treat patients with GBM. So this was a patient that was 62, they had a performance status of 70, so maybe they weren't able to do work, but could do most of their daily activities on their own. What if the patient were age 70 or age 80, or they required home health aid to dress them in the morning? How might you change your recommendation for treatments?
I think for these patients, generally we would not want them coming back and forth to the hospital for 6 weeks of radiation, Monday through Friday, the way that we treated the prior patient. And so in this situation, we consider shorter courses of radiation. And for those patients that, have a fair performance status, you can do 3 weeks of radiation still combined with chemotherapy. For patients with, really bad performance status, you can definitely consider just single modality therapy. In those situations, usually we look at MGMT status. And so MGMT, it's promoted when it's hypermethylated. Those patients respond better to temozolomide. And so for patients that are hypermethylated, then we would consider temozolomide by itself. For those that are not hypermethylated, we would consider radiation by itself. And that could be anywhere from 1 week of treatment, giving 25 gray in 5 fractions, or 40 gray in 3 weeks and 15 fractions can also be considered. As well as, if someone has a really poor performance status also, I think we should not forget about just best supportive care with steroids as well.
There was an interesting question by Taylor about a very specific question, actually asking about grid therapy in glioblastoma for patients with recurrence, or maybe if they have a bulky non-operative disease. So this is there's a resurgence of interest in this particular, what's known as like spatially fractionated radiation therapy, which is not new, but as with kind of more frequently and currently used technologies may have a role to improve outcomes for patients. And so this particular approach involves treating what are often like bulky tumors with non-uniform dose to maybe deliver like selectively more potent doses to the bulk of the tumor itself, but perhaps be more sparing of normal tissue. I would have to say in the CNS, I haven't heard much discussion about it, although it is an interesting concept. I would think that one of the factors that would need to be addressed in association with that research concept would be a better identification of the tumor extent, because gliomas, unlike, for example, brain metastases or many other solid tumors, are very infiltrative. I use the term fingers, and they very much are like these interdigitating fingers with normal intervening brain. So actually identifying that and treating it even with normal doses of radiation is one of the challenges and one of the limitations we recognize in the field. But that's a very interesting question. I'll make brief mention of tumor treating fields that was asked about. And this is an FDA approved technology, actually. It's not a drug, it's not radiation, but it's a therapy that has been shown in a phase 3 randomized trial to be associated with improved survival in patients with tumors such as these, glioblastoma. So the way that it's offered to patients just in their routine course of care is after they finish radiation therapy and they get a bit of a break and they continue to get chemotherapy, then they may initiate wearing this Optune device.
Wonderful. Thanks so much, Dr. Kim, Dr. Harris. So we'll go on to the second case now. This is a case that's very typical that I might see on my current rotation with Dr. Hineker, actually. So this is a 6-year-old girl who presents to the emergency room with headache, nausea, and vomiting. No really relevant medical history. Examination showed papilledema and abnormal gaits. Labs showed some electrolyte abnormalities that are typical of dehydration, and an MRI of the brain was ordered, which showed this. The radiologist reported a heterogeneously enhancing mass in the posterior, I think it was, in the posterior fossa protruding into the roof of the fourth ventricle. It was T1 hypointense. There's some sort of imaging characteristics of it. So we'll start our poll, what your leading differential diagnosis might be. And then Dr. Hineker, could you maybe comment when you see a posterior fossa mass in a child, what's your differential and what are you thinking about?
Yeah, definitely. So I think these are good options on your differential that you gave them as choices. I think that for this tumor, my top 3 would be medulloblastoma, ependymoma, I guess maybe pilocytic astrocytoma, although it doesn't quite look like that. If you're thinking more diffuse midline glioma, that would be something that's really intrinsic to the pons, and you'd see a real infiltration of the pons, not a normal looking pons and something compressing it. And so just on imaging, sometimes we try to guess what these are before the patient goes to the OR, which is really, the first step is getting the maximal safe resection. But yeah, I agree with our students that it looks like a medulloblastoma. Some ways you can get a hint on imaging. Medullos often arise in the vermis of the cerebellum and extend into the fourth ventricle from the roof. They often are enhanced with contrast and are T2 hyperintense typically, and T1 hypointense pre-contrast. Often also have diffusion restriction. Just in terms of their anatomic extent, they're more often, I guess, central like this, less often going into the foramen of Luschka, which we think of as ependymoma more typically, although it's not always true. Ependymoma also maybe more commonly goes down into the cervical spine as well, whereas pilocytic astrocytoma, you'd expect to see more of a cyst and a well-circumscribed cyst with potentially a nodule, enhancing nodule in it as well. So those are just some clues you can get ahead of time, but you won't know for sure until pathology.
Thank you, Dr. Hineker. Yeah, so this patient underwent a surgical resection once the operating room, but one thing that was noted post-operatively is that she had mutism, so she wasn't speaking, had difficulty swallowing, and emotional lability. Dr. Hineker, what's she experiencing? Is this permanent? Is this typical?
Yeah, so I'd say not typical, but unfortunately also not uncommon. It sounds like posterior fossa syndrome, which is a syndrome that can occur starting within a day or two post-op, and can continue on for many months and take a long time to resolve, or sometimes it doesn't fully resolve, it just improves. It's something like 50% of patients still have some residual symptoms at a year later. The etiology is not totally well understood, but thought to be due to either injury or edema or vasospasm after surgery, and typically more of like a large kind of central tumor, sometimes with brainstem invasion. So we have patients where this can be very significant for them, and it takes a lot of rehabilitation to improve the symptoms.
And so the pediatric neurosurgery team and the neuro-oncology team completed the workup for this patient. We already saw the preoperative MRI. Like the previous patient who had a glioblastoma, they did also do a postoperative MRI to see whether the full tumor was removed or whether there was some residual disease. So this patient had a gross total resection. There was nothing left over in the brain. They also did an MRI of the spine because medulloblastoma is one of the tumors of the central nervous system that can disseminate through not just the brain, but also the spine. And fortunately, that hadn't happened in this patient. And then a lumbar puncture was also performed, and the CSF was clear of any malignant cells. So just as Dr. Hineker guessed, it was indeed a medulloblastoma, WHO grade 4, classic histology without any of these large cell or anaplastic features. And then something that Dr. Harris had mentioned is the molecular classification of brain tumors. So this tumor was also tested for specific mutations. And what was interesting is that this was a Wnt-activated tumor that was non-sonic hedgehog activated, and it was MYC negative. And so we'll talk about that in a little bit, but this specific patient does have a Wnt-activated tumor. So in addition to being what we call standard risk for medulloblastoma, which is very classic, it's been around for a long time, and it's based upon imaging features and the histology, what additional prognosticators might you think about in terms of what a favorable subgroup is? We'll ask the audience first. Okay. So share those results. And then just to round out the discussion of risk for this patient, you see here the different features that define whether a patient is standard risk or high risk, which is important to radiation oncologists regarding how they manage patients. But this patient was older than 3. They had a gross total resection. They had classic histology, no dissemination of the medulloblastoma through the rest of the CNS based upon the MRI and the lumbar puncture, and it was within the posterior fossa. So we would call this patient standard risk. And then related to the poll question, Wnt-activated tumors tend to be a more favorable prognosis. But Dr. Hineker, can you expand on why molecular subtyping even matters for medulloblastoma and how we use it?
Sure. I think just like in adult tumors, the more we learn molecularly, the more we see that these are sort of many different subtypes of tumors that are really more driven by their biologic and molecular features than just kind of the clinical sort of guidelines or histologic guidelines we've relied on in the past. So you see here, this is a nice slide, I think, from the SJMB St. Jude medulloblastoma study 12, or related to that anyway, and showing different subgroups of medulloblastoma, kind of the demographics that they typically appear in, what you typically see clinically, and what maybe gene expression is associated with it most commonly. And so Wnt is a very specific type that occurs in children, especially, or younger children, and typically has a very good prognosis. And so this is starting to be important in terms of molecular subgroups, because with these different outcomes that we see among different groups is this movement towards stratifying patients with de-escalation of therapy and seeing if that's safe for patients who have a very favorable prognosis, and intensifying therapy for those patients who we think molecularly have what's going to be a badly behaving tumor.
Great. Thank you, Dr. Henniker. And Dr. Harris, can you talk about for medulloblastoma after surgery, what is the standard of care, and why does this SJMB-12 protocol or other protocols that think about adapting risk, what can we really change about the treatment, and why does the molecular status matter?
Yeah, so, unfortunately, the standard of care for these patients is something called craniospinal irradiation, where for traditionally a standard risk patient, we would treat their entire neuraxis, so their brain, the entire spinal cord, sort of down to the bottom of the thecal sac, to a dose of 23.4 gray, usually in 1.8 gray fractions. And so this, generally, causes, a lot of long-term side effects for patients, be it deep, problems neurocognitive, different problems with endocrine function, as well as treating so much of the vertebral bodies. We also impact height, not just from an endocrine standpoint, but also by decreasing the growth just from the radiation directly on the vertebral bodies. And so if we can find patients where we can, de-escalate therapy, which again, traditionally, decades ago, we were treating these, in 36 gray. And so decreasing to 23 gray has been found to be safe. There have been clinical trials that have tried to decrease it even lower, which were unfortunately unsuccessful before we really understood these different molecular subgroups. And so now, these studies are being done to determine, particularly in this WNT subgroup, is it safe for these children to have, dose de-escalation down to from 23.4 gray down to anywhere between 15 to 18 gray, depending on the study. St. Jude's study is 15 gray. COG has a clinical trial as well, and theirs is 18 gray for this subgroup. And also, there are, other molecular subgroups which are more aggressive. And so for these patients, we're trying to consider, is escalating therapy going to be of benefit for them?
I completely agree with Dr. Harris. One thing that I forgot to point out is just that, as he said, the treatment's very intense and it leads to significant long-term side effects. It's also really very effective in the sense that, for standard risk medulloblastoma, we expect about an 80%-ish cure rate. So it's intense and associated with side effects, but most of these kids are cured, which, as he noted, means we just have to be careful about de-escalating and lowering that survival rate, as we saw in one COG study that showed you can't really give 18 gray to kind of all comers for standard risk.
So there was an earlier question about proton radiation for glioblastoma that I think Dr. Kim commented on. And traditionally, this craniospinal irradiation, and maybe at many institutions, it's delivered with multiple different fields because we're treating such a large, area of the CNS, the CSF, anywhere the CSF touches. So maybe as we close up this case, can the panelists talk about what technique they use? And then the question of proton radiation was raised related to glioblastoma, but how do you think of it for medulloblastoma and other pediatric cancers?
So unlike for the case of protons for glioblastoma, protons for craniospinal radiation in pediatric malignancies is very commonly and appropriately employed as the first option if available, because of what you can see in the far right panel there, essentially a complete sparing of all the organs that sit anterior to the spine. in addition to some additional helpfulness for protecting or sparing regions in the brain as well. We here don't have proton therapy. And the technique that we use to mitigate that high dose into the viscera is what you had commented on, a technique known as volumetric modulated arc therapy, or VMAT, where you can create very conformal or kind of more restricted distributions of dose to the area you want to treat. It is very kind of more technically demanding. And so there are some neat sort of more advanced ways in which we can assure that what we're delivering and giving to the patient is accurate, with some kind of more advanced technical capabilities with imaging patients essentially from the top of their head to the bottom of their tailbone, as well as ways in positioning them to make sure that it's the best and most accurate treatment for them.
Excellent. Thank you so much, Dr. Kim. So you can see here the different dose distributions for proton therapy and photon therapy, and the different types of photon therapy, both the conventional 3D type and then IMRT and VMAT to reduce dose to the brain. Okay, so we have about 5 minutes left. We'll just touch on a few points with the last case, which is brain metastasis. Dr. Harris had mentioned this in the differential for glioblastoma, but just quickly to present this case, this was a 45-year-old woman with no medical history, presents to the emergency room again with very similar symptoms, nausea, vomiting, and blurred vision. Their neurologic exam is there that showed some difficulty with coordination. And the MRI showed this here, a mass in the posterior fossa. So she was initially started on steroids to improve her symptoms. We'll skip this poll for now, but just like the first case, the patient had a CT scan, and unlike the glioblastoma case, there was something noted in the lungs, suggesting that there was cancer in the lungs, and indeed this ended up being a lung cancer. This specific brain tumor, just like the previous two cases, was removed. The pathology showed a metastatic cancer. And I'll open it up again to the panel. How does the management of metastatic tumors to the brain differ from the primary tumors? And what might you recommend for this specific patient, given the different options?
So one of the awesome things about radiation oncology is how multidisciplinary patient care is. And I think it's extremely, every case we've discussed so far does employ that. It is equally, perhaps if not more so, the case for patients with metastatic tumors, whose often their primary issue is not what's going on inside the brain that you would treat as a radiation oncologist, but actually what's going on in the rest of their body, which tends to be what may limit their life. So working closely with a medical oncologist is very important. There are some key points here that are very relevant to just how we care for these patients in 2021. The reason that the EGFR mutation positivity is important here is because now, as opposed to even like 5 years ago or, and not too long ago, there are now medications that can actually penetrate or have activity into the central nervous system that could complement what we can offer as radiation doctors. And so in this case, after the patient has surgery, they should appropriately see you as a radiation doctor, because the best evidence we have is that the radiation will keep it from coming back in that area, much better than just watching it. And we even have evidence that tells us that doing the focused radiosurgery is better than doing the whole brain if you want to preserve their neurocognitive function, even though additional tumors might come back elsewhere in the brain more commonly. And then on a more investigational basis, a tyrosine kinase inhibitor is the kind of therapy, the kind of class of medications that would target this EGFR mutation. That's not yet been investigated so much in these patients who have surgery, but that, as well as related tumor types, is an area of ongoing research.
Thank you, Dr. Kim. And so this specific patient, I think the radiosurgery was mentioned, and that's one of the great things about radiation oncology is the different techniques that we can use. It's not all forms of radiation aren't the same. We have the ability to shape it and deliver different types of treatment based on the indication. So we'll just close with this. This was the treatment plan in our department for this patient. Again, they had a brain metastasis to the cerebellum, new diagnosis of lung cancer, and this tumor was removed, and indeed it was a metastasis. We treated the patient with radiosurgery. So just maybe one final question for the panel. What is the role of radiosurgery? How does it differ from the normal radiation that we use? And maybe how do you deliver radiosurgery at your institution?
So the role of radiosurgery is to provide an ablative, highly focused dose of radiation. It was initially designed, by neurosurgeons with gamma knife in the 1980s. And really the goal of its employment here is to prevent local recurrence at the site of the surgery. At my institution, we use just standard linear accelerators to perform radiosurgery, either a trilogy or a true beam.
At our institution, we similarly use a platform that's specifically designed to treat kind of like things on a sort of a millimetric or submillimetric scale, linear accelerator-based radiosurgery. And we here, and it can vary by institution, as you'll see from our responses, we tend to use a 5 treatment or 5 fraction regimen. So there could be a range. This might be a little on the larger side to do a single fraction of radiosurgery. So most institutions probably would deliver anywhere between 3 to 5 treatments.
Yeah, and at Stanford, we use CyberKnife. It actually was developed here, and so a lot of people kind of pay a lot of attention to it. So that typically, I think we would treat this over 3 fractions. It's using a non-coplanar approach with real-time image tracking.
Great, thank you so much. So I think we're just about out of time. So let me just go to, we have a couple wrap-up slides.
So thank you to Dr. Miller for being the moderator. Thank you to all of our panelists for a wonderful discussion. And always thank you to Nav for coordinating everything. Please be sure to fill out the post survey. We do appreciate your feedback, and we do give gift cards after a little raffle. There's a question about recordings. Recordings will be on the website in the next few weeks, but there's also the recordings from last year, so you're always welcome to watch those as well. But these lectures will go on the website soon. Next slide. And please go to radoncvirtual.com. We'll have everything on there, including there's meet and greets from different institutions on that website. And then next slide, and you can always reach out to one of us. There's lots of different virtual rotations, clerkships. There's even faculty at different institutions under the Medical Student Resources tab that you can reach out to. And then next session will be on head and neck, and that will be on July 23rd at 12 p.m. Pacific time, 3 p.m. Eastern time. So please sign up for that as well.